Welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. We are delighted today to welcome again one of our dear friends and a true giant in the field of plastic surgery and hand surgery, Professor Neil Ford Jones from UCLA. Dr. Jones joined us a couple of months ago where he discussed proximal nerve compression syndromes. And tonight he will be discussing a topic that is somewhat different, but very close, near and dear to our hearts with regards to microsurgery. He'll be discussing toe-to-hand transplantation in children. Dr. Jones really needs no introduction, but just a quick recap. As we all know, he's an internationally renowned surgeon in complex hand surgery and microsurgical reconstruction. He completed his undergraduate studies at Trinity College in Cambridge and Oxford University, followed by his medical degree at Oxford. He then completed combination general surgery, neurosurgery, and orthopedic surgery at the University Hospital of Wales, and he's a fellow of the Royal College of Surgeons. He then completed plastic surgery residency at the University of Michigan, followed by a fellowship in plastic surgery at the Royal London Hospital, and after that, an additional fellowship in orthopedic hand surgery at the Massachusetts General Hospital. Dr. Jones was chief of hand surgery at UCLA for 15 years, as well as the microsurgery and hand surgery fellowship director up until 2008 for 15 years. Prior to that, he'd been chief of hand surgery and co-director of their hand fellowship at the University of Pittsburgh. After his 15-year stint at UCLA, he was recruited to UC Irvine to be the chief of hand and director of the fellowship at Irvine until fairly recently, 2018, when he returned to UCLA to resume his hand practice there. He has authored over 270 peer-reviewed articles and book chapters, has presented over 700 presentations at national and international conferences. Dr. Jones has been a visiting professor at universities all over the world and obviously across the US, and has delivered many keynote addresses at these conferences as well. He's edited 2 textbooks, the microsurgical reconstruction of the upper extremity, current state of the art, as well as operative microsurgery. I think most importantly, perhaps, Dr. Jones has had many significant leadership positions. He is a past president of the American Society for Surgery of the Hand in 2015-2016, where the theme of his presidential address was the importance of microsurgery in surgery of the hand. He also is a past president of the American Society for Reconstructive Microsurgery back in 2008-2009. So he has contributed significantly to two of the main societies in our field. During my travels last year, I had the privilege of visiting Buncke Hospital, and those who were here for the first lecture that Dr. Jones delivered have seen this part, but I wanted to repeat it. There was a section called Scott Levin and Friends, and when I saw this picture, it just so happened that I was visiting all 5 of these gentlemen during my travels last year, and obviously here you can see Dr. Jones next to Scott Levin and Raja Sabapathy. And I had the privilege of visiting Los Angeles, and Dr. Randy Sherman was nice enough to arrange a beautiful dinner for us in LA, and we had a really, really phenomenal time, great outdoor dinner. This was pre-COVID time, but I think in LA, pretty much every night you can have dinner outdoors, pre or post-COVID. But it's been a really fun few years getting to know Dr. Jones and spending time with him. This is actually a great lunch that we had in Australia at the combined Australian and American Hand Society meeting with Dean Soterianos on the top left and Jonathan Isaacs on the bottom right. Dr. Jones, thank you so much for being with us. It's really an honor to have you, and we're really looking forward to hearing your talk today.
Okay. Then I'll begin. Well, Babak, thank you so much for that introduction again. Thank you and Rudy and Greg for inviting me back for a second time. So I must have done reasonably well the first time. So this time I'm going to talk about a microsurgical topic. And obviously I'm sticking my head out talking about toe transfers in the heaven of toe to hand transfers in the Buncke Clinic, and obviously I obviously have to pay tribute to Harry Buncke, and he is really the giant on whose shoulders all of us follow. But I did get to know Harry for a few years when I came out to UCLA, so I feel very grateful to have had that time to spend with him at meetings. What I'm going to do is concentrate on talking about toe transfers in children. And I'm going to talk about toe to hand transfers for trauma first in children. And then I'll talk more about toe transfers for congenital differences. So if we start with the thumb amputations in children are relatively rare compared with adults. And obviously, one of the key indications for an amputation in a child is to try and replant it if at all possible. And that means sometimes going to the dorsal radial artery with a vein graft. Maybe we've even done vein grafts all the way from the elbow down into the hand and thumb. And occasionally you can do ectopic replantation. But the difference between children and adults is that there's a tremendous psychological impact on the parents. And there's usually blame attributed to one or other of them, which can, in fact, sometimes wreck a marriage as well as having a child missing a thumb. The critical level for a thumb amputation is the same in a child as it is in an adult, and that is at the midpoint of the proximal phalanx. So the child in the middle and on the left, the same child has a relatively functional thumb, but the young girl on the right-hand side over here is at the level of the MP joint, and therefore that's a critical level. I seem to have lost the ability to, there we go. So in terms of secondary reconstruction, if you're not a microsurgeon, then there are really three options for reconstructing a thumb. One is to use a non-vascularized bone graft, and usually that's a toe phalanx. You can do distraction lengthening, and obviously you can policize either a normal finger, usually the index finger, or an injured finger. So metacarpal distraction lengthening is occasionally useful in children, if they're older anyway. And usually you do an osteotomy either through the metacarpal, sometimes through the proximal phalanx. You apply these mini distractors, and then instead of distracting at 0.5 or 1 millimeter a day, you divide this into 4, and so you turn a little screw on the distractor and do that 4 times a day, or the parents do, so that you lengthen by 0.125 or 0.25 millimeters a day. And you can sometimes get up to 3 centimeters of bony distraction. In children, this may spontaneously regenerate, but occasionally, as the children get older, you may have to do a secondary bone graft. And many times you have to do a third stage, and that's usually a Z-plasty to deepen the web space. But frankly, I think this is, if you're a microsurgeon, this is really an obsolete technique nowadays with toe transfers. But here's just an example showing you that's almost 3 centimeters on that metacarpal. And then this is a fairly, I think, a teenager, if not somebody who's close to 20. And so we then secondarily bone grafted him and plated him. But even though you'll see this close to 3 centimeters elongation on the X-ray, it looks far less in real life. So I'm not a great proponent of it. As far as I know, there are no studies of policization in children for trauma other than burns, and usually those policizations are actually remnants of an injured finger. So they're not like a policization that I'll show you for congenital. Toe to thumb transfers and toe to finger transfers in children are actually incredibly rare, and maybe you can tell us about the Buncke experience. But I think a lot of hand surgeons are very reluctant to consider toe transfers in children compared with adults. And this is the literature that I can see. You can see Sheb Dovchenko in Russia has done a lot, Simon Kay in England, obviously Fuqian Wei. But many of these are mixed thumbs and fingers. And then we recently published our series of 21 toe to thumb transfers about 4 years ago. And then you go to meetings and you present this and you get the argument, well, you know, you guys, if all you have is a hammer, then the whole world looks like a nail. You're always wanting to do microsurgery, but I think that's a bit of a put down from people who can't do microsurgery. The question is, are toe to thumb transfers or toe to hand transfers any different in children from adults? And they are technically probably quite similar, but the dynamics between the surgeon and the family, i.e. two parents and the child, are totally different. And you have two parents with incredibly high expectations. The vessels are definitely smaller and they're more susceptible to vasospasm. I think it's technically a lot more demanding than adults, although even adults it's demanding, and they're very difficult to manage post-operatively. That being said, they usually have better tendon and nerve regeneration than adults, and these toe transfers will grow as the child grows. I'm not going to go very much into the technique or the anatomy. I think obviously Greg, I'm sure, will have talked about this before, but we use 90-90 interosseous wiring. We don't tend to use plates in children. In terms of the flexor and extensor tendons, you've got to be able to think on your feet and do tendon transfers or tendon grafting if there's not enough extensor or flexor tendon in the recipient hand. And similarly with, if there are not digital nerves available, you have to think about using nerve grafts or even end-to-side nerve transfers using the superficial branch of the radial nerve or the dorsal sensory branch of the ulnar nerve. The venous anastomosis is usually end-to-end on the dorsum of the wrist. The arterial anastomosis is either end-to-end into either the radial or the ulnar artery, or end-to-side. And I think in children, just like replants, you really have to liberally use lots of skin grafts. You don't put any tension on the venous anastomosis. I'm a great believer, and we've written about this, using the pulse oximeter. And you can use these pediatric pulse oximeters, and you can get an oxygen saturation that should be similar to the contralateral hand, and obviously the pulse rate should be the same. If the pulse rate differs, it's one of two things: either the arterial anastomosis has gone down, or there's a problem with the contact of the pulse oximeter. But this oxygen saturation, we don't know what the lower limit of normal is, but I tend to get really worried even around 90 to 92%. So these are the indications for toe to thumb transfers in trauma, and it's based on a classification system that we originally developed for congenital differences. So R1, R stands for the radial side, so R1 is just an absent thumb. R2 is the thumb and index finger, R3 thumb, index and middle, R4 is thumb, index, middle and ring, and then an R5 or a U5 hand, meaning from the ulnar side, is absence of all 5 digits. And this allows you to compare apples and apples and oranges and oranges, and literally somebody can tell you over the phone at night, just like describing a fracture that's dorsally angulated or apex dorsal angulation. You know immediately what the X-ray looks like, and if somebody says, I have an R3 amputation, then you know it's index, middle, and thumb. So in terms of reconstructions of the thumb in children, there are these 3 main areas. If you have an isolated thumb amputation, but it has to be distal to the CMC joint. So anywhere from the CMC joint out to the functional level, which is the mid-proximal phalanx, we call that R1, U4, or just shorthand R1. And we can also, as you'll see later, classify the level as a W, an M, or a P. Obviously, W is wrist, M is metacarpal, and P is phalanx. And then there are multiple amputations of fingers and thumbs. And then, obviously, the most extreme is amputation of all 5 digits. Fu Chan Wei calls this a metacarpal hand. We call it an R5 hand. So here are some examples of indications for toe transfers. This is an isolated thumb, R1. This is a groin flap on an R3 hand, amputation of the thumb, index, and middle fingers. And you could even say this is an R4 because there's a little bit of the distal phalanx missing. This is not an indication for obviously a toe to thumb transfer, but this is a U4 hand, meaning they're missing all 4 fingers, but they have an intact thumb. And then an R5 amputation of all 5 digits. We tend to use the second toe in children, and you're all familiar with the anatomy of that. And we tend to use the second toe because of the growth in the metacarpal, so that you can get more length as the child grows using a second toe as opposed to using a great toe. But as the child ages, then we tend to think more of using a great toe. And we can isolate it on the dorsalis pedis and the first dorsal metatarsal artery, or we can just take the first plantar metatarsal artery and add a vein graft. So here are some examples. This is a 7-year-old child with an amputation at the mid proximal phalanx. Here's the second toe transfer. And if the video plays, this just shows you the results of a second toe transfer to the thumb. The second toe, as you're all familiar with, tends to adopt a slight flexion contracture at the DIP joint, and some of these children we go back on and fuse the DIP joint, but many times the flexion contracture is actually helpful in terms of giving you that flexion posture for pinch. Here's a 3-year-old with an amputation now much more proximally at the MP joint level, and again the second toe transfer, and this is the result 2 years post-operatively. This is a much older child, and so now you begin to think that maybe we should use a great toe, and rather than using the entire great toe, in this case we're going to use a trim toe transfer, originally described by Fu-Chan Wei, and I think also at the same time by Joe Upton, but essentially it's sculpting the great toe into hopefully an exact replication of the normal contralateral thumb by removing the tibial side of the proximal phalanx and the tibial side of the distal phalanx, and obviously making the nail the same as the contralateral side. And this is just showing you can make an incision through the tibial collateral ligament, which is here and here, and then you can shave down the proximal and distal phalanges, and then on a back table reconstruct the tibial collateral ligament and close the skin. And this is the result. Unfortunately, I don't have a comparison slide with his opposite thumb to show you the similarity. These are more difficult. This is a young child with a lawnmower injury, and you can see this is just distal to the CMC joint, so it's still an indication for a toe-to-thumb transfer. If the CMC joint, as you'll see when I talk about congenitals, if the CMC joint is gone and is involved in the trauma, then usually we do a policization of the index finger. But we can make up for this discrepancy in length by taking a lot of second toe metatarsal. And here's the second toe being dissected. You can see liberal use of split thickness or sometimes full thickness skin grafts. And then the result in terms of pinch and grasp 2 years later, and then just showing you the donor site. And certainly in Caucasians, a straight line closure here is very inconspicuous. And unless you counted 1, 2, 3, 4 and suddenly realized there weren't 5 toes, you'd be hard pressed to know that a toe had been harvested. So the second toe certainly gives you a very inconspicuous donor site. When you start to see children, and again, they become more and more rare, where there's a thumb amputation as well as multiple fingers, you may have to perform some sort of soft tissue coverage, and sometimes that may be a free flap, but I think most times in a child, we've used reverse radial forearm flaps, as I'll show you. You can do them as an emergency, but usually we do them electively. And then as the child gets older, you can do, this is a burn, and you can not only preserve the length of the metacarpal, but you can release the web space between the thumb and other adjacent fingers using a groin flap. But obviously in a young child, it's very difficult to immobilize a young child with a groin flap. This is a 10-year-old with a groin flap, and you can see the hyperpigmentation. This is an R3 hand, or you could say even an R4 hand, but an excellent small finger. So if you put a toe transfer here, they'll get excellent pinch and grasp. And this is just showing you the results 2 years later, and even in this African American, a relatively inconspicuous donor site. This is an explosion, a grenade injury with multiple amputations of the digits and a very restricted web space. So before you do any toe transfer, this web space has to be opened up. Sometimes we'll remove the index finger metacarpal, and I'll show you examples of that later on. But that in itself will get you a much deeper web space. But in this case, this was the case that I was showing you with a groin flap, and you can thin down this distal edge of the, or the distal 8 to 10 centimeters of a groin flap, literally down to the dermis, so you get an incredibly thin piece of skin here. And then obviously in this child, because he's missing so many fingertips, I think Harry was the person who put this forward as a concept. If you use the entire great toe, you now have a much greater area of sensate skin on which the other compromised digits can oppose to. So this is an entire great toe transfer, and obviously Harry is the founder of this surgery. Unfortunately, I think John Cobbett, who may have done his fellowship with Dr. Buncke, scooped him and did the first one, but after that, Harry did many, many more. Now you might say, well, this is way too big. It's not way too big. It's the same size as the other side, but obviously, as you can see here, but obviously these are amputated digits, and I think the child was perfectly fine using. I think we took out his index finger. This is his middle finger. This is his ring finger. And there's his small finger, and he pinched between his great toe transfer and the ring finger and didn't have another toe transfer. What about amputations of the thumb and all the fingers, the metacarpal hand or the R5 hand? And I'm going to show you these examples. This is another grenade injury. This is a burn injury over here. And I'll talk about this in the next few minutes when I talk about toe to finger transfers for trauma. So just looking at toe to thumbs in the series that we just published, I think I think it was last year, there were 19 children, 21 toes, and you can see most of them were isolated toe transfers, but the next most common was the R5 hand, the metacarpal hand. And of the 21 toes, the great majority were second toes, but 7 were great toes, and 4 of those were either trimmed or wraparound variations. Interestingly, we had no postoperative explorations, so we had 100% success. All of them regained what they thought as a child was normal sensibility. All of them either regained opposition to the remaining 4 fingers, which would be a modified Kapenji score of 5, or to a remaining digit on the ulnar side of the hand. And Jim Chang looked at some of them. Growth is preserved and it's equal to the contralateral toe if that contralateral toe is available for measurement. There have been no subjective problems with gait, and I'll show you a case later with 6 toe transfers. And all the parents are incredibly satisfied with the reconstruction. So for toe to thumb transfers, I think this is a single stage procedure. It certainly provides far greater length than any metacarpal lengthening, and it preserves all the remaining fingers compared with policization. Certainly the second toe is the most inconspicuous donor site, and for the best cosmetic result, now we tend to use the trim great toe or the Morrison wraparound in an older child. For a younger child, we'll use the second toe, and then, as I say, for older children, we'll use the great toe or when there are multiple fingers that are also amputated to give that that pinch and grasp a much greater surface area of sensate skin. What about finger reconstruction? Well, finger reconstruction, I think in the United States for children and for trauma is much rarer than toe to thumb transfers. And paradoxically, toe to finger transfers for congenital differences are actually more common than toe to thumb transfers. The indications are these two. Amputation of all 4 digits, so that's U4, meaning from 4 fingers from the ulnar side. The U4R1 means that the thumb is intact, or amputation of all 5 digits. The interesting thing is that in children, multiple amputated fingers still with a thumb present, the U4 hand, is incredibly rare, and I don't think I've ever seen one. And I started to think, why haven't I? And the reason is that obviously microsurgeons somewhere are going to do their best to replant 1 or all 4 of those fingers. And even with a transmetacarpal amputation, these are obviously absolute indications for replantation. And again, in contrast, a U4 hand for a congenital difference is the most commonest phenotype, as I'll show you later. So here's a very young child, gets his hand in a exercise bike, wipes out his superficial palmar arch, multiple digital nerves, metacarpal fractures to all 4 fingers. So it's not really a complete amputation and a complete replantation. It's a revascularization, but it's much more difficult. And in this case, you can rapidly fix the metacarpal fractures. You can put a vein graft and reconstruct the superficial arch and do end-to-side anastomoses distally into the common digitals. And this is 5 years later with no further surgery, either for the tendons or for the nerves. This is a transmetacarpal amputation. The little finger is just wasted. And so the amputation can be replanted, but only for, 3 fingers and thumb, and again with excellent functional results. So in terms of doing a toe transfer to reconstruct a finger, you're either going to use a single second toe, or you're going to use bilateral second toes, either staged or simultaneously, or as Fu-Chan Wei has shown in adults, a combined second and third toe transfer as shown on the right. So I'm going to just show you 2 metacarpal hands in children, and the options for reconstruction are either to use a second toe from each foot. You can use a great toe from one foot to reconstruct the thumb, and then the second toe from the opposite foot to reconstruct an opposable digit, or you can use a great toe to reconstruct a thumb, and then a combined second and third toe from the opposite hand to reconstruct 2 fingers. So here's this grenade injury. I think this child is from Palestine. You can see the amputation level is very, very proximal, and there's a lot of skin graft over on the radial side here. So we used a reverse radial forearm flap, and we've described a series of these now. And if you take a length of the radial artery, the proximal radial artery, when you flip this down, then not only will this reverse radial forearm give you skin coverage, but it suddenly gives you arterial inflow into the first dorsal metatarsal artery, or the first plantar metatarsal artery. So the first stage here was to do the reverse radial forearm flap, skin graft the forearm, and the first second toe, the first of the double second toes, was put into the thumb position. And then 6 months later, we came back and used the contralateral second toe and did the anastomosis end to side into the radial artery of the flap right in this area here. And luckily, both toes survived. And this is a 2-year follow-up, and you might say, well, this is pretty not cosmetic looking. It looks like a Krukenberg. It's way superior to a Krukenberg. He has excellent grasp and pinch right now. And here's a 10-year follow-up. And this this child went on to high school and university, and eventually we actually, this third toe here was a little bit shorter, and so we actually did a ray amputation of this to make it more cosmetic, but a very, very functional hand. This is an example. I'm not sure it's yet come into publication, but I'm sure some of you have seen it before. But this is a burn from Yugoslavia in an 8-year-old child when his father set him alight with gasoline. And so these are amputations of all 5 digits out at the level of the MP joints or in the metacarpals themselves, skin graft over both the dorsal and palmar surfaces. And so again, what you have to do is make that web space between the thumb metacarpal and, in this case, we took out the index finger metacarpal, deepen the web space with a dorsal flap, full thickness skin grafts. We did this on both hands, pin the thumb metacarpal out, and then that sets the stage for toe transfers. And in this case, we couldn't afford to lose any of them. And so we did staged great toe transfers again to get more sensate skin to oppose to furthest toe transfers. And this is showing you the, and Greg and Rudy and Babak can talk, with great toes you can sometimes get fantastic flexion through the flexor hallucis longus. And even when we did the great toe transfers, he was able to pinch against the remnant of his finger metacarpals. And this is shortly after the left hand was reconstructed. And then I was planning just to do 1 second toe here and 1 second toe here. And the child said, why don't I have 2 from each foot? So we actually did combine second, third toes from each foot. And I was again planning to do a metatarsal amputation, and he said, no, I want to keep these 2. So this was certainly flying by the seat of our pants, and so we did. This is just the hopefully it will start, maybe will not. Yeah, there it goes. This is just a computer animation of the great toe transfer to the thumb, and then the combined second and third toes into the I think we put them into the ring and the small finger position, and took out the middle metacarpal here. So this is pre-op. This is after we'd done the 3 toe transfers on the left. This is pre-op, and after we'd done the 3 toe transfers on the right hand. And this just shows you his pinch and some grasp. And this is showing the left hand with the same ability. And so this is what he was left with. And we waited 4 years before we published this to get formal gait analysis of his feet. And this is just showing you some of his functional outcomes. The dash was 27, which is pretty amazing. We've actually tested him against a number of hand transplants, and also a number of myoelectric and bionic prostheses, and he beats everybody. He is able to do everything with these hands, and his gait analysis was reported as absolutely normal, which is incredible. But it was done in Utah, so maybe, hopefully there's nobody from Utah, but maybe they have less stringent criteria. But even if you look at this, this is called the Southampton hand score. It's a very, very good way of looking at function in hands. And his right hand was 76 out of 100, and his left was 81 out of 100, and his 2-point discrimination is virtually normal. So I think, in conclusion, for trauma in children, I believe that toe to thumb transfers really should be the gold standard. And we were not allowed to use that description in the article in the Journal of Hand Surgery. But I think it really is the gold standard. And in terms of toe to finger transfers for trauma in children, I think it definitely should be offered to some of these children if they're missing all 4 fingers, and certainly if they're missing all 5 digits. In terms of decision making, I think you have to explain all the options to the parents, both conventional options and toe transfers. You explain the morbidity of each donor site. You explain the risks of failure, which are obviously significant. You can show them pre-op and post-operative photographs, which I do, but this, I've learned, this is the way to go. You have to arrange for a family that is considering a pediatric toe transfer, have them meet with another family whose child has undergone a similar procedure. And you can read all the articles in the literature, but I would say don't depend on algorithms. You've got to individualize the reconstruction. These are so important in these young children. So let's move on to toe transfers for congenital differences. And this is just showing you, these actually are slides from Graham Gumley, who's a great friend of mine in Sydney, Australia. This is the development of the hand in the developing fetus, and hopefully it will play. And just to give you an idea of how amazing development in the womb really is. So the interesting thing about toe transfers for congenital differences is that they really haven't developed to the same extent that toe transfers in adults for post-traumatic reconstruction have. And so we've looked at a large series of children's hands, 308 hands in 274 consecutive children who were referred with congenital amputations, for want of a better word, or congenital absence rather, of their thumb or fingers. And you can actually break it down into 15 morphological and radiographic phenotypes. And so these are the radiographic absent digits, so starting with the thumb, and this is where we develop the classification system, the R1 to R5. These are the ulnar phenotype, so a U5 is the same as an R5, but this U4 hand we found is actually the most common phenotype of all congenital hand differences. So absence or little nubbins of all 4 fingers, but an intact thumb. And then you can also see the various central deficiencies. So C1 means that you're missing the middle finger. R2 means that you have an intact thumb and index. U2 means that you have an intact ring and small finger. And this is the most common one. This is the so-called cleft hand or lobster claw, where it's a C3, so they're missing index, middle, and ring fingers, but they've got an intact thumb and small finger. So embryological classifications are totally useful. It's totally useless in guiding you in terms of any reconstruction. And we feel that it's really the morphology and the radiographic anatomy that is the most logical way of trying to reconstruct these children. But if you look at the 15, only 6 of them are really absolute indications for toe transfer. So all the 5 R's, R1, R2, R3, R4, R5, and then the U4 hand. So here are the examples: an isolated thumb, thumb and index finger, thumb, index, and middle finger, syndactyly here, syndactyly here. This is a symbrachydactyly with missing the thumb, index, middle, and ring fingers, but a remnant of small finger. And then this is the most common one, an intact thumb, but these nubbins of symbrachydactyly of the U4 hand. So we've gone over this. The main challenge is that you are talking to the parents. They have a child already with a very deformed hand, and you're trying to tell them, I can take your toe and make a finger out of it. So they have very, very high expectations, just like the trauma family, but they're also very, very apprehensive, and they're reluctant to even accept any degree of small failure. And then obviously all of us, some are less than others, but all of us are reluctant to offer a surgery that may have a small chance of failure. So how do we get over parental apprehension? The bottom line is that many of these families are realistic and they're prepared to accept the loss of a toe transfer to try and improve the function of their child's hand. And if they are realistic like that, then they're a good family to go ahead with. If they're not prepared to risk that loss of a toe transfer, then it's probably better not to offer them a toe transfer. Joe Upton tends to give them or makes a prosthesis out of dental alginate and puts it, makes impressions of the hand before and after. Obviously, I started using photographs and videos, but now I have every child speak or visit with a family who's had a child who's undergone a toe transfer. And as some of these children are now in their teens and even in their 20s, a young child or family can meet with somebody who's, in high school or in university who's had a toe transfer. And this is what we call child-to-child counseling. So this child is about 2 years old. This one has had a toe transfer for exactly the same congenital anomaly. So this is a U4 hand, symbrachydactyly. This boy, this is his thumb, and this is the toe transfer in the small finger. And I think he's maybe 10 now. And she gets it even at the age of 2. And the interesting thing with the internet is that some children who are 8 suddenly see maybe mine or Joe's or Greg's cases on the internet, and suddenly these children get it and they say to their parents, there's a surgeon in San Francisco who can make my hand better. And the child brings the parents along to the consultation. But you get tremendous reticence by other hand surgeons, and they will say, well, the thumb, even though the thumb provides 40% of hand function, they'll say, well, these children adapt to their impairment over time, which I think is rubbish. Or they'll say, well, we can reconstruct them conventionally. Or they'll say these hands can be improved with a prosthesis, which again I think is quite ridiculous. But I think it comes down to either because of the surgeon's training or because of their reluctance, they're not going to embrace a complicated reconstructive procedure that might have a small risk of failure. Which toe? Just like trauma, we tend to use the second toe in children for fingers and even for thumbs. But as the child gets older, we'll use the great toe for reconstruction of the thumb. What age? Nobody knows. I think the optimal timing is probably somewhere between 2 and 5 years. Alan Gilbert, in Paris, when he started doing them, was doing them at 6 months, but they're difficult enough at 2 or 3 years of age. And it really depends on your coronary arteries, and maybe Alan Gilbert's coronary arteries were in better shape than mine. Doing them at 6 months. Interestingly, there are some transfers that have been very functional even up to 15 years of age. But I think the concept, just like with any congenital hand surgery, an early toe transfer gives you the best chance of cortical integration. But I think this is most people are moving into this 2 to 5 year time period of doing them. We've been over this. I think it is technically demanding. You may have to use 10-0 or 11-0 sutures, a 75 micron needle, and you're right up at 25 power magnification. And these congenital differences are really very susceptible to vasospasm. And literally you have to wake the child up sometimes to break the vasospasm. So these are the indications for reconstruction of a thumb with a toe transfer, just like I've gone over in terms of the trauma. But in terms of an isolated thumb, it has to be distal to the CMC joint. They must have a CMC joint and hopefully have some thenar muscles and some remnant of the metacarpal. So we call this an R1 U4M is the level of the congenital absence. And then absence of the thumb, the R2, the R3, and the R4, and then obviously absence of all 5 digits. So these are all congenital cases now. So here's a congenital constriction ring, great thenar muscles, thumb metacarpal. This is dying for a toe transfer rather than polycizing this index finger. This is an R2 hand with syndactyly, an R3 hand with syndactyly. This is a symbrachydactyly, and then absence of all 5 digits, an R5 hand. So in terms of an isolated absent thumb, if the absence is proximal to the CMC joint, so it involves the trapezium and the scaphoid, these are usually seen in radial longitudinal deficiencies, and they're usually the Blouth 4 and Blouth 5 hypoplastic thumbs. It's very hard to provide a foundation for a toe transfer. There is a series out of China that may be promising, but I think most people would say in this case, an R1 U4 at the wrist level, W, you use the index finger to polycize it and don't do a toe transfer. So here's a Blouth 4 hand, a floating thumb. Here's a Blouth 5 hand, complete absence. And here's the floating thumb. Here's it polycized. And this is a bilateral polycization for absent thumbs. So many times you can get very, very good results from polycization. Here's a child with a polycization for, I think, a complete absence of the thumb.
Okay. Open up, touch the fingers. Touch the fingers. Slow, slow. Go one by one again, slow. Okay, open the hand again and do it slow.
However, there are lots of other absent thumbs that don't fall into the Blouth classification. So there are symbrachydactylies, congenital constriction ring syndrome, and transverse failures that you cannot classify on the Blouth classification, yet they're congenital absent thumbs. And so this is a Blouth 5, but this is not a Blouth 5, this is not a Blouth 5, and this is not a Blouth 5. And all of these will have a much better functional hand if you can reconstruct them, and probably with a toe transfer. So anything distal to the W, so at the metacarpal level right here, or the phalangeal level here, are indications for a toe transfer. And these are the children with symbrachydactyly, congenital constriction ring, and transverse failures. So this is the child I just showed you. So this is an R1 U4 at the metacarpal level. There's a great metacarpal, there's a CMC joint, there's a remnant of proximal phalanx. However, unfortunately, she has an above knee amputation of the left leg. This is her right foot, and the big toe is not very good. So we have to use the right second toe. And this is the result, which I think is good, both functionally and aesthetically, 2 years post-operatively. This is a Hispanic girl, and they tend to develop hypertrophic scars. So the foot is not the greatest. This is a case that Jim Chang wrote up. This is a rapidly progressive venous malformation that took over this young girl's thumb and started to take over her index finger. They did embolization, sclerotherapy. This thing continued to grow, and it was so heavy she couldn't get her hand to her mouth. So we basically treated like a malignant tumor and did a radical resection literally down to the dermis to try and prevent this recurring. Left the metacarpal and the CMC joint and the extensors and the flexors and the digital nerves. Did an immediate toe transfer. And I didn't quite get the rotation perfect, but functionally she had excellent sensation and excellent opposition, and has so far refused to have any rotational osteotomy of the thumb to get it in better position. Occasionally you can use a third toe, and this child, you can see she also has congenital constriction ring. The second toe is not good, the big toe is not good, the other foot was just terrible. So we had to use a third toe transfer to reconstruct her isolated thumb. And this is her reconstruction. And then just to show you gait, this is 8 weeks after the surgery, running down the corridor. And then this is showing her function unscrewing a bolt. And then in these more very severe radial deficiencies, the R2, the R3, and the R4, then these are all definite indications for toe transfers to opposed to the remaining fingers. So here's an R2 hand, here's an R3 hand, and here's another R3 hand, all due to congenital constriction ring syndrome. And when you look at these children in congenital constriction ring syndrome, it's just like somebody's amputated the thumb in utero, and you can find the extensor tendons, you can find the flexor tendons all the way out to the level of the amputation. You can even find the digital nerves. So these are far better to do because the structures, the plumbing is there, compared with symbrachydactyly, where there may be missing nerves and missing tendons. And this is her after reconstruction with a second toe. We use the second toe metatarsal to try and lengthen this middle finger there. Here's another congenital constriction ring. Again, excellent thenar muscles and thumb metacarpal and an intact CMC joint. However, when you look at the foot, you can't use the second toe, you can't use the third toe. Similarly on this foot, you can't use the big toe. All you can use, and this is a 5-year-old, is the great toe on her right foot. So we did actually a trimmed great toe transfer on this girl, and this is her result 5 years post-operatively. So functionally, it's, I think, really good, and aesthetically, there's very little difference between the toe transfer and the contralateral normal thumb. And again, the problem with the hypertrophic scar in the foot that I yet haven't mastered. If you want to do these surgeries, these are the children you have to find, these so-called unilateral atypical cleft hands. They're really R3 hands. This is the foot with an abnormal great toe. There's no thumb. There's a syndactyly between the ring and the small finger. And the pediatric orthopedic surgeon called me up and said, we're going to amputate this great toe because they can't fit shoes on. Can you use it? So yeah, yes, we can, because this is a freebie. Even if this fails, the child is no worse off. But these are very, very abnormal great toes. And so you have to transfer them as a very abnormal great toe and then come back and do osteotomies or arthrodeses to straighten them out and correct them. And so this is a concept that Jim Chang and I wrote about many years ago about spare parts for toe transfers. And basically a spare part is a toe that is being amputated by the pediatric orthopedic surgeon so they can be fitted with shoes, but we can use them for reconstruction. Here's another bilateral cleft hand and feet. So this is an R3 hand, syndactyly on both the hands. We can release this first, and then you can see how abnormal these great toes are. And this is just showing you, I think we've corrected this one with osteotomies. This one still has to be done. But now this child can not only pick up a large object with just one hand, but it also gives them excellent bimanual grasp. What about reconstruction of absent fingers? Again, the pediatric hand surgeon who can't do microsurgery is going to tell you, well, we can take care of these just using non-vascularized toe phalangeal bone grafts, or we can do distraction lengthening. But I think they are relatively obsolete and certainly far inferior to toe transfers. In terms of non-vascularized toe phalangeal bone grafts, the question is, do they grow? And you can find papers that will say yes and no. Jim Chang, when he was a fellow, looked at a big series of Shriners and compared with the toe transfers, and literally non-vascularized toe phalangeal bone grafts only grow about 36%. The toe transfers, the growth was, there was always growth in 100% of the toe transfers. But you have to do the surgery early, before 15 months. you have to leave the periosteum intact, and you have to reconstruct any flexors and extensors and collateral ligaments. I think it has a part to play. Here's a transverse failure, and I certainly wouldn't do a toe transfer here or here. But I think you can lengthen these fingers with these non-vascularized toe phalangeal bone grafts, but you have to warn the parents that the toes that you leave behind will subside and will usually fall back to the level of the size or the length of the fourth toe. Distraction lengthening can be done, I think, in an older child. This is a brachydactyly of an index finger. We're not going to do a toe transfer, obviously. And you can do the same matter of distraction osteogenesis as I showed you before. So the indications for toe transfers to reconstruct fingers are two: either a U4 hand, so the nubbins of symbrachydactyly, but with an intact thumb. It may be symbrachydactyly, it may be an ulnar longitudinal deficiency, it may be congenital constriction ring or even transverse failure. And then again, this is symbrachydactyly with nubbins for all 5 digits. So usually the reconstruction is 1 second toe into the ring or the small finger position, something on the ulnar side of the hand that will give you pinch and grasp. And if you have enough surgeons and the parents are willing, then you could do bilateral second toes, 1 from each foot. You can't put them together, you have to separate them. So usually we put them into the middle and the small finger position. And you can do this as a 2-stage procedure, or if you have enough surgeons, you can do it simultaneously. So here's a symbrachydactyly. I told the parents they needed to consider a toe transfer. They said, absolutely not. We'll go with toe phalangeal bone grafting. And so we lengthened this index finger, and I thought this actually was a pretty good result. In a 2-year-old, this proximal phalanx of a second or third toe is anywhere between 13 and 17 millimeters in length. In comparison, an entire second toe at a 2-year-old stage is about 5 centimeters, 50 millimeters. But actually, when I saw this, I thought, this is not bad. And so it remained for a couple of years. And then serendipitously, this child ran into at a county fair somewhere in the wilds of Pennsylvania. And this was when I was in Pittsburgh, and ran into a family whose child had had another toe transfer done. And immediately this family saw the results of the toe transfers. They called up and said, you know, you were right. I should have had a toe transfer. We should have done a toe transfer. So this taught me about counseling of parents to parents or child to child. And so we did the toe transfer, and I don't know whether you can see this, but this is the median nerve, this is the ulnar nerve. And when we looked at the median nerve, there was literally just a few wisps of digital nerves going to the thumb, and we had to bring the nerve grafts over to the ulnar nerve over here. This is before the clamps were released, and then afterwards. And this is the follow-up of pinch and grafts. Once we did the toe transfer, this totally dominated the non-vascularized toe phalangeal bone graft, and this was virtually excluded from the child's pinch and grasp forevermore. This is the same sort of thing. So a U4 hand, these are the nubbins, a very, very difficult family, upper middle class, very, very difficult to, I used to spend 2 hours or so in clinic trying to talk to them about the risks, and they said, no, we'll go with the non-vascularized toe phalangeal bone graft. Here it is, useless, worthless. And eventually they agreed to have the toe transfer, but they didn't. They wanted to keep on with the nubbins, and to this day they've kept the nubbins. But immediately with the toe transfer, she had excellent pinch and grasp, the donor site in the foot. She went to high school and she became a psychology major, and I want her to do, as her project, I want her to look into some of these children, the psychosocial aspects of some of these children having toe transfer. But she can type faster than I can, even with the thumb one toe transfer. And she keeps
About
these
typing
nubbins,
just left-handed without typing that. Can you do that?
This is actually this is another family, very difficult to counsel, but very, very gratifying result. So the toe transfer into the small finger position, and this is her 7 years postoperatively. And yet another one just showing you grasp and pinch of these U4 hands, just putting one toe transfer into position. This is a child with probably, this is probably a central deficiency. So this would be a C3, R1, U1 hand. And the question is whether you lengthen these with non-vascularized toe phalangeal bone grafts or whether you do two toe transfers. So we did this in a staged into the middle finger first, and then 6 months later we did another second toe into the ring finger position. So hopefully this gives a much better grasp to these 3 digits and the donor site in both feet on the right hand side. And finally, if you can muster probably 6 surgeons, so 2 surgeons on this foot, 2 surgeons on this foot, 2 surgeons on the hand, you can potentially do a simultaneous harvest of bilateral second toe transfers. And this is just showing you the 2 toe transfers immediately post-op. And this is where he started, the x-ray. This is 7 years post-operatively. These toe transfers don't flex like normal fingers. They tend to move at the MTP joint. But they have sensation, they grow, and they allow this child to ride a bike, play baseball, and grasp and pinch. And finally, can you reconstruct these hands? These are R5 hands, again, pure symbrachydactyly with the nubbins, and lots of people say, no, you can't reconstruct these children. But I would defer from that decision. So here's a child. There's a little nubbin here and here, and there's a rudimentary thumb. But what we did was to do a second toe into the thumb position first, and then 6 months later come back, and you can see these end to side. These are the 2 digital nerves. There's not enough recipient nerves in the hand, so we've done end to side nerve transfers, and again, lots of skin grafts. So this is the radiographic progression from where he started. This is the first toe transfer into the thumb, the second toe transfer into the small finger position. This is a very important slide. So you can see these are chromic catgut. So this is less than or around about 6 weeks. These are not quite dissolved. So this is the thumb, and this is the toe transfer that's been done into the small finger position. This has no sensation, but by looking at the 2 toe transfers, the child can now start to pick up objects without even having sensation in the toe to small finger position. This is him 6 years postoperatively. Obviously, these hands are not normal, and they do essentially side to side pinch, but they have great sensation, they grow. And this is tying your shoes without looking is actually a very difficult thing to do. But there is no way that a child who had symbrachydactyly like this child had, with no digits, no thumb, no fingers, could tie his shoes either with a prosthesis or with non-vascularized toe phalangeal bone grafts. And he's got a lot of strength here. And this is him at 12 years. When you ask him, there is nothing that he can't do with this hand. He has no complaints. He can do everything in his life that he wants to do, play sports, and no problems with the donor feet. And this is one more. Again, you might say there's a remnant of thumb and small finger, but again, this is probably a C3 hand, a central cleft hand, and these nubbins. And so we decided to do toe transfers into the thumb and small finger position. This is 11 years postoperatively. and I don't know whether hopefully it won't play the music, but she actually plays the violin for the state orchestra in Mexico. It's a very abnormal posture of the hand if you watch. So this is our, we've done, I think, 122 pediatric toe transfers for congenital differences, 98 children. So several of them have double toe transfers or bilateral. Our re-expiration rate is 8%. Our failure rate, these are terrible for both me and the team, and more so for the parents. But it's still, I think, reasonably comparable with any other free flap surgery. So 97.5% success rate. All of them regain sensibility. As I say, motion at the MTP joint is probably better than the PIP and DIP joint motion. All of them can get pinch and grasp. Toe to thumbs do far better than toe to fingers. The epiphyses remain open and they have a memory, so growth is exactly equal to the contralateral toe. It's not greater. And we initially looked at the satisfaction by the parents using this outcome instrument called Pediatric Outcomes, PODCI. And then we gave it to some of these adolescent or teenager children. And the children's PODCI scores are even higher than the parents. So these children psychosocially have very, very good outcomes. So finally, another, well, the giant, I suppose, of American hand surgery, Sterling Burnell, said, "To those who have nothing, a little means a lot." And I think Harry Buncke is obviously another giant, and he introduced us all to toe transfers, and I've maybe stood on his shoulders just a little bit and done a little bit more in toe transfers in children. So I think we're 5 minutes over time, so I apologize.
Well, Neil, thank you so much for another phenomenal talk. I think it's really a tour de force of toe to hand transplantation, both for congenital differences as well as for traumatic absence of the thumb and fingers. Had a few questions of my own, and then we'll open up. Actually, looks like Dr. Bala actually is on with a question. Professor Bala, are you there?
Yeah. No, Neil Jones is one excellent talk. My only question is, will you ever explore the hand in congenital hand difference to see how the vasculature is? Because some of these times now we see them some congenital difference in even the vasculature, so where we cannot put the toe or anything into the hand. Have you ever had such a problem of the congenital anomaly in the vasculature of the hand in congenital difference?
So Bala, thanks for the question. It's hard. I think what you're asking is, have you ever had seen vascular anomalies, and have you ever had to bail out? So I'll answer it. So when we, to start with, when I started doing this, we were angiogramming everybody's hand and everybody's foot. And then when I came to LA in '93, the Shriners didn't have a radiology department that could do angiograms, and the chief of the LA Shriners said, "We're not going to pay for you for your children to go and get angiograms." So basically, we then started examining the patients just with a Doppler, and then obviously going ahead. And what we would do is we would explore the hand, and many times there are vascular anomalies. We did one on Friday, not a child, but we did well, she was, I think, 21, so she's not quite a child. But we did a case on Friday, and we could hear a good Doppler between the great toe and the second toe. But when we explored it, there was no continuation of the dorsalis pedis into the first dorsal metatarsal artery. So we went to the first plantar metatarsal artery. And then as we were dissecting the tendons, there was a tiny first dorsal metatarsal artery that was present distally in the web space, and then it dived into the interosseous muscles and had no connection with the dorsalis pedis. I don't think that's ever been described, but that's, I'm getting off the subject. You just have to think on your feet, but there are, I think, either one or two children that I think we backed out of completely, because even though we could get a Doppler of the radial or the ulnar artery at the wrist, the vessels were just so tiny that we thought we were not going to get great flow. And we've done 3 children. We haven't written it up yet, but we took vein grafts all the way from the brachial artery right down to the toe transfer. So, literally in a child's arm, literally, I don't know what it is, 15, 20 centimeters of vein graft from end to side to the brachial artery all the way down to the inflow to a toe transfer, and those have worked. So I think you can do it. I think the answer to your question is you have to be prepared for all manner of vascular anomalies, nerve anomalies, tendon anomalies, and the same thing with trauma. Somebody may have debrided the tendon or the nerves. So you just have to think on your feet and be prepared to do what you have to do in terms of taking a vein graft, a tendon graft, a nerve graft. But we no longer angiogram these children because of the history of the Shriners, and we don't tend to do the angiogram even if we do them at UCLA or UC Irvine. I just got out of doing it. Maybe it's risky, but there it is.
Instead, what we do, we first dissect the hand and see that there is no problem with the vessel, recipient vessel, and then go for the toe dissection.
Yes, no, I agree with you. We tend to start the hand first, but on the other hand, in terms of trying to save time, we also probably start the toe transfer very close to that same time. So in the unlikely event that we can't do the toe transfer, and I think it's very, very unlikely that you can't do a toe transfer, especially because you can make up a tendon or you can make up a nerve, that the worst that could happen is that maybe you've made some incisions on a toe, and then you have to back out at that stage.
Babak, I have time to ask for one more question.
Sure, of course, go ahead.
Yeah. See, you showed a case of a vascular anomaly of the thumb.
Yes.
Huge anomaly of both index and the thumb.
Yes.
In such situations, you could always see the median nerve is also involved. Median nerve up to the lower third of the forearm is involved. That means the sixth and the selecting a distal nerve, donor distal nerve is a problem. Many times I used to do the division of the median nerve on the lower third of the forearm and connect them to the distal nerve of the respective finger with a sural graft. For such a case which you have shown, you have done a nice toe transfer. What do you do with the nerve? We are easy to get a donor nerve?
I think I understand your question. In terms of that vascular malformation, there's not much in the literature about these progressive, especially venous. Obviously, in arterial, rapidly progressive arterial malformation, they're really nasty, and in a way you have to treat them like malignant tumors, and virtually all of them, I think, come to some form of amputation. The venous malformations are less nasty, but as you can see in that girl, they start to take over, first one digit then another. In her, the median nerve was not involved. The median nerve can be involved in things like macrodactylies and lymphangiomatous malformations. And sometimes, again, with macrodactyly, you may have to, especially if it's very rapidly progressive, you may have to consider an amputation of the involved fingers and leave the normal fingers. In terms of let's say we can't find a recipient nerve, we sometimes will harvest another part of the superficial peroneal nerve or another part of the deep peroneal nerve, or go to the sural nerve and use nerve grafts, or we will try and use a branch of the superficial radial nerve and flip it, let's say for a thumb, flip it from dorsally, palmally, so that maybe we can connect it to the ulnar digital nerve of what's going to become the ulnar digital nerve of the new thumb. And you can do the same thing with the dorsal sensory branch of the ulnar nerve. I hope that answers the question.
Yeah. Thank you so much. It was an excellent presentation. Thank you so much, as usual. Very good work. Yeah, thank you. Bye.
Thank you, Professor Bala. We have a question from Professor Dungchul Lee in Seoul, South Korea. And Dr. Lee is asking about the positioning of the toe to thumb transplant. There are thoughts that the younger generation are using their thumbs a lot more for things like texting, for example, which potentially not only requires maybe a different angle, a rotation versus a more of oppositional grasp, but also may require more flexion at the interphalangeal joints. And so their question is what are your principles for this if, in a younger patient who may want to use their thumb a lot more for texting? And also, does that affect your decision to do a great toe versus a second toe, which may have more flexion of the IP joints?
I don't think I would make a decision based on them wanting to text. I think they will adapt, just like I showed you the girl on the computer keyboard. They will adapt with whatever you give them, as long as they have length and sensation. So I wouldn't, if it was a very young child, I wouldn't suddenly say, we're going to do a great toe transfer on you, because when you're 8 years old or 10 years old, you're going to be, texting 4 hours a day. I think in terms of the thumb, we usually set it up in exactly the position that hopefully the base of the metacarpal guides us to, because if they have that CMC joint, and that's why toe to thumbs do far better than toe to fingers, they have so much mobility at the CMC joint, they can do a lot with a toe to thumb transfer that they can't always do with a toe to finger transfer. Mm-hmm. But in fact, we were this case on Friday we were doing for trauma, but she only had a thumb and no fingers, and so we actually set the toe to finger in the small finger position. She actually was way back, right at the level of the distal carpal row, so bone fixation was incredibly difficult, and what we ended up doing was drilling a hole in the capitate and then seating the second toe metatarsal in this hole, and it actually was very, very stable. But then we turned the toe transfer, and I'm not sure I can show it, but instead of coming down to, let's say, touch the distal palmar crease, we turned it through literally, or rotated literally through 90 degrees. So she could do this, and I can't rotate my little finger. So she had tip to tip, pulp to pulp pinch. And again, that then you have to think, is that going to interfere with how the flexor tendons and the extensor tendons work? So it is very difficult positioning a toe to finger in these metacarpal or R5 hands. I think it's much less difficult positioning a toe to thumb transfer.
Yeah, definitely. I think our experience mirrors that as well. A quick question about spasm. You mentioned that it tends to be more of an issue in children than it is in adults, and I think most of us would agree with that. Short of using papaverine and warming and the usual things, are there any other adjunctive procedures that you think would potentially help, like regional blocks, or is there anything else that you think of in trying to break the spasm besides waking the patient up?
That's the only one that I've found. I think in the literature there's a paper that says 20% lidocaine is far superior, but I can, and apparently it's on these crash carts, but I can never get somebody to raid the crash cart and give me 20% lidocaine. So I use papaverine, I use hot water. Sometimes we haven't done blocks on some of these young children, but we do it on adults, and then finally waking the patient up is the one thing. And I tell the anesthesia. The other thing is volume, or if the pressure is running at 80 or 90, and also temperature. There are so many things that can go wrong that ruin your whole day. So all of those things I try, and then I say, lessen the anesthesia, and literally they're starting to move their arm, and then suddenly there's a booming pulse in the vein graft or whatever, and then the toe goes pink.
Yeah, I think the pressure, I think, is a huge thing, and we notice that a lot too. Is oftentimes when there's just not much flow, you look up and all of a sudden you see the systolics in the 80s or low 90s, at least for an adult, and then as soon as they wake up a little bit, you're right, the spasm does tend to break. And then one last question before I open it up for Dr. Greg Buncke to make a comment or question. You showed that case where you had taken the great toe and also the second and third toes on both sides. Any idea, or do you have any comments on the mechanics of the foot as far as walking? Clearly, the patient, was better off with that. I'm curious to know how the patient is able to walk and how the mechanics are kind of long term.
Well, I can send you the gait analysis if you want. But that is the official report of the gait analysis. But this child, plays football. There's a video of him playing football. He can run half a mile, and that's all I can say. That was not what I was planning to do. It was him saying, "I want my fourth and fifth toes."
I think it just goes to show, I think a lot of what we're told and a lot of what's potentially intuitive is actually not the case. I mean, I think when Harry started doing his toe transplants, there was a lot of pushback from a walking mechanics standpoint, and then he did them, and then there were actually gait studies done with some of the local podiatrists that actually showed that the patient was able to compensate. And oftentimes they would actually shift more of the weight would be on the second metatarsal head. And I think it just goes to show that I think, especially in young children, oftentimes what we think may be an issue actually ends up not being an issue. They're able to compensate pretty well.
Yes.
Greg, I know you're on. Did you have a question or comment for Dr. Jones?
Yeah. Neil, thanks so much. That was really a tour de force. I've got to say, these cases are incredibly hard, and you have to have a lot of courage to do them. And but it's worth it. The results are so great. Just seeing that kid run down the hallway is just so much fun to see after 8 weeks. I had a question about your use of the pulse oximeter for monitoring. We were interested in that actually when pulse oximetry was kind of new, and had some difficulty with the pulse oximeter. Nelcor, we actually talked to Nelcor about this and had them come up here and try to work with us, but it seemed like it was too sensitive, that we'd have a replant that was doing badly and clinically looked horrible, but we'd still get some kind of oximetry reading and sometimes some numbers that were normal. Have you had that experience? Or maybe the oximeters have changed now and become less sensitive? What's your experience?
I can't remember who, I think it's Hollis Caffey, I think, first described it for pulse oximetry in about 3 replants. And And so I got interested in it in Pittsburgh, when I was in Pittsburgh with Bill Schwartz, because we were fiddling around with the 8 megahertz. No, it wasn't the 20 megahertz Doppler, which is now the Cook monitor. But we did a lot of stuff in the lab, and both with the 20 megahertz Doppler and with the pulse oximeter. And you're right, you can get things that are on the back table totally dead with no inflow.
Yeah.
That's not giving you readings. So I'm worried just like you are. However, if you do what we call differential pulse oximetry, if the pulse rate is 100 on the opposite hand and 100 on your toe transfer, and you suddenly lose it, then it's one of two things. And I tend to believe the pulse oximeter rather than my own intuition saying maybe we won't take the patient back. It's either something's gone wrong with the pulse oximeter, it's not making contact, or you've got a problem with the arterial anastomosis. That one I think is pretty uniform in not giving you a false positive or a false negative. Where you have the problem is I don't know where the cutoff for the venous anastomosis is, but it could be actually very high. And that's why on some of them, even at 92 or 90% saturation, if the other side is 99, 98, I tend to get a little bit worried. So I think we don't know for sure about the venous side of things with the pulse oximeter, but it's certainly my go-to monitor for toe transfers at the moment. I haven't come across anything that's better, apart from obviously, sticking the toe transfer, and sticking it, can throw them into spasm. So sometimes I shave off some of the dermis right just at the hyponychial fold and let them bleed through that. And then obviously a handheld 8 megahertz Doppler on the toe transfer itself. But again, people are sticking that, well, not sticking, but they're fiddling around with the 8 megahertz Doppler, and that in itself may induce vasospasm.
Sure.
And I think the morphology of the waveform potentially is actually just as important as the number. I think if you, at least we do this with a lot of the devascularized, that come in pre and post. Yes. That presence of that really nice waveform is a reassuring thing. I think I'm not quite sure how to evaluate that in the setting of congestion, but at least for inflow, I think that I definitely like to look at that as well, in addition to just the number.
Yeah. We've had a couple of older children that we've sent home earlier with a pulse, with 2 pulse oximeter boxes. So, not 2 days later, but normally I keep them for 7 or 8 days. And maybe on the 4th or 5th day, they're beginning to get a little bit antsy, and they're a teenager. Yeah. And so we've said, you understand this, you know what these numbers mean. Here are the 2 boxes, and you can't live, you can't go and stay anywhere other than, an hour away from here.
Right.
But if you want, you can go home with these 2 boxes, and it's worked so far. But it's just like an airline pilot, flying the plane there, but for the grace of God go I. I've flown 1,000 planes and I've not gone down, but maybe that's the next one is going to be the one that crashes.
Right.
Well, thank you very much.
Well, Neil, thanks so much again for a phenomenal talk. I think these are some of the most difficult cases that one can do in the hand, and I think the stress level when you operate on a young child like that in what is basically an elective operation, but it certainly is a life-changing operation. I think the stress level is quite high, and I think I want to commend you on the obviously your mastery of this, and also really pushing the envelope and showing everyone what the standard is, or what the standard should be, if you will, for reconstruction of the hand and for congenital and for trauma in young children. Thank you so much.
Okay, well, thank you for inviting me again. It's been a pleasure and great to see lots of old friends. I see Scott Hansen is there.
Yes, yes.
Hey, hi Neil, great to see you.
Hi. You did some of these cases, I'm sure, didn't you?
I know. Well, yeah, my comment, I didn't want to keep you on the line, but yeah, the symbrachydactyly child tying his shoes, I did that one with you years ago. And, you know, they're very inspirational, Neil, and very impressive. You know, these children, I guess they all stop in LA. They don't make it up to Northern California, but you're the guy to do it.
2 more years. I'm not going to be like Harry going on till I'm, whatever it was, 85.
Well, Neil, thanks again so much, and please stay safe down in LA with all the fires and everything.
Everybody listening in, and thank you again.
It was fantastic. Hope to see you again soon in person. Thanks so much. Take care.
Bye-bye.
Bye-bye.
Thanks again. See ya.
Bye.